She thinks that everything is fine because she doesn't have cancer and she doesn't have irregular bleeding. We just put it away and think, oh, it happens to all of us. This is normal. And in reality, it's not normal.
You know that moment when the day finally quiets down and instead of relaxing, your brain gets louder? The questions start showing up. Why am I so tired? Why does my anxiety feel different than it used to? Why does my life look fine but feel off? You don't have time to think about it during the day, so it waits for you at night. This is What the Shift, the podcast for those 2 a.m. thoughts you keep trying to ignore. The ones about exhaustion, people-pleasing, overfunctioning, boundaries, changing bodies, shifting identities, and the quiet realization that nothing is wrong, it just can't keep going the same way. I'm Gia Lacqua, and if it's been keeping you up at 2 a.m., it's trying to tell you something. Welcome to What the Shift. If you've been having the 2 a.m. moments where you realize something is shifting, you are in the right place. Welcome back to What the Shift. I'm your host, Gia Lacqua. Today, I am so excited to introduce you to Dr. Faina Gelman-Nisanov. Dr. Faina is a highly skilled board-certified OB-GYN. She's committed to providing comprehensive gynecological care, including well women care, family planning, and hormone replacement therapy. She is passionate about women's health. She's an advocate for patients' rights. She strives to empower her patients to make well-informed decisions about their health. Her goal is to provide a comfortable and safe space for women to receive and accept care and educate women on their bodies, how they work, how they break, and how they heal, so they can be empowered by knowledge to navigate this complicated world and our complicated lives. Dr. Faina, welcome to the show.
Thank you so much, Gia. It's so wonderful to be here with you.
I'm thrilled to chat with you today. I always enjoy talking to you, and I love talking women's health. So this is going to be an amazing episode. So let's
Absolutely.
start with, you see women all day, every day. Tell us, what are you noticing that most women are maybe not noticing about their own bodies right now?
Many women disregard pelvic pain. They disregard it in a very interesting way. They just say, oh, they don't bring it up necessarily at the first visit, maybe sometimes even 3 years in. So I'm talking to my patient and she says, well, I've been having painful periods and pain during sex. I'm like, for how long? She's like, oh, for the last 10 years. I'm like, you've been my patient for 3 years. Why haven't you said anything? I think that
Right.
we are trained in our childhood, especially the older generations, to take our pain quietly and to disregard what we're feeling. And when we have the pain, the pelvic pain, pain during sex, the painful periods, we just put it away and think, oh, it happens to all of us. This is normal. And in reality, it's not normal. And I end up investigating a lot of these things and trying to find some solutions for patients. But I think that pain, pelvic pain, pain with intercourse is a big sign that women just don't think that they should be discussing with their doctor.
So interesting. So the pelvic pain, and I guess probably a lot of other specialties as well, where women are experiencing symptoms, and I see this in the women that I work with as well. They're experiencing physical symptoms, and to your point, they are dismissing, ignoring, normalizing. There's a lot of conditioning that happens where we're trained to disregard or push through that pain when actually our bodies are giving us a sign or a signal that something's off. So I appreciate that insight. I think that's a really important point. So something we're normalized, what I'm hearing you say is the pain. And you're thinking this isn't normal. Are there other things that you see that we're normalizing that medically, are maybe common but not normal?
Yes. So, into the conversation of menopause, women experience a lot of things other than hot flashes when they're perimenopausal and into menopause. They experience brain fog, they experience irritability, changes in mood that could reflect as anxiety, they experience joint pains. And I only know to identify these things when I have a conversation with patients perimenopausally. And if they come in, they say, oh, I'm feeling fine. And I know they're over the age of 40, and I automatically ask any of these things. And they say, oh, yeah, so actually I'm experiencing almost all of them. They don't realize that this is what this is. And many times women, because of good increased popularity of mental health care, they're reaching out to their primary care doctors and to their therapists for treatment for anxiety and depression. When in this age group, it's important to consider perimenopause and to treat the mood disorders with hormones. Because if you're not experiencing relief with antidepressants or anxiety medications, you should be considering hormones. And likewise, when I start patients on hormones, I warn them it's very possible that you truly have anxiety and depression that's outside of the perimenopausal sphere. We may have to treat that with the
Sure.
correct medications. So women feel like these symptoms aren't perimenopausal when indeed they are.
Yeah, that's a great point because now there's a lot more education and awareness around what those symptoms are, whereas previously they were either unspoken or maybe, the research wasn't there. But now we know that these are symptoms. And so to your point, when women go to the doctor, we don't think to say, yeah, I'm irritable and I have brain fog because that seems like every day, especially if you're a mom. The mom brain and we're told, oh, that's a normal part of life and it's being a woman and it's stress. But your point is no, those are actual
Yes.
symptoms that we need to consider as, part of something else. So I think that's a really important point. And a lot of the women that you see, I imagine, are high performing, high capacity. They're used to holding it all together.
Yes.
And I'm curious, like, what does that actually do to the body over time? What are you seeing?
In reality, we only allow ourselves to fall apart when we have a moment to ourselves, and to the world, we seem very put together. But in clinical practice, when a woman is worked to the brim, to the edge of her ability, we see a lot of things that she's ignoring and she's failing to bring up in her visit. She just thinks that everything is fine because she doesn't have cancer and she doesn't have irregular bleeding. Everything is fine. When in reality, they do have the brain fog, the insomnia, the night sweats, the hot flashes, and again, the pelvic pain. Stress can definitely relate into pelvic pain discomfort during intercourse, as well as irregular periods, skipped periods or frequent periods. All of that can occur. And sometimes women don't realize that it's the stress that's causing this. And it's very hard to relieve stress. It's very hard to relieve our social, environmental life stress. But many
Mhm.
times it's a conversation about what we can be doing to help them, specifically when it comes to pelvic pain, which I think is a very tricky one that stress causes. Pelvic pain is difficult. It's a difficult thing to treat. I'm not personally a pelvic pain specialist, but I did work with them for many years and I had the pleasure of working with pelvic floor physical therapists, which I love, 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 love. And it's a complex diagnosis involving a care team, a primary person, be it your gynecologist or a primary care doctor, referring you to the pelvic pain specialist, possibly to a urologist, as well as to a pelvic floor physical therapist. Because our stress, for some reason in women, falls into the vagina. It falls into the pelvic floor muscles and it comes out as frequent urination, recurrent UTIs, recurrent vaginal infections, pain during intercourse, pain during our periods. And that needs to be investigated and treated with many modalities, not just one.
Your point is stress is affecting women sometimes when it comes to pelvic pain or other gynecological symptoms. And it's hard to pinpoint. I guess part of the diagnosis is understanding what's causing it. But for a lot of women, it is the stress that we're under. And I'm curious. So you mentioned a few frequent urination. What are some of the other symptoms that you see in high achieving women that we're just kind of chalking up to life or being stressed out?
Of course. So, insomnia. Sometimes we think that we're
Mm.
having insomnia because of stress, but it could be because of something else. So, it's definitely important to address the insomnia. Once our sleep is out of order, it's going to cause big problems for the rest of the body, especially the older we get. When we're younger, when we're, late teens, early 20s, we actually can get away with very little sleep and still be high functioning. The older we get, it's very, very important for our mental health and stability to be able to sleep. I believe for women, it's 8 to 10 hours through the night. And I think everyone's going to laugh because nobody sleeps that much, especially if they're high performing women, especially if they have children or anyone that they have to take care for. And the purpose of the sleep, right? We have to sleep. We have to go through the different stages of sleep. We have to have restful sleep, uninterrupted sleep. We're not getting up at night to think about something. We're not getting up at night to
Mhm.
pee. We're not getting up at night to have a hot flash. None of that has to happen. That way, if we have a restful night, all of our stages of sleep, our cortisol levels are regulated. If our
Yeah.
cortisol levels, none of this is happening. If our cortisol levels are dysregulated, we are now in a constant stress state, which means you can't think correctly. You can't do things correctly. You're sleepy in the middle of the day. God forbid you take a nap, break your sleep cycle. Next, you gain weight. And even if you don't gain weight, you can't lose the weight. When your body is in stress, it's going to hold on to your fat cells. It's not going to let them go. It thinks that you're about to starve and is holding on to everything. So it's impossible to create homeostasis for yourself if not for the sleep. So it's very important when we have high stress levels to reassess what's going on with your sleep. Is it truly your stress or is it something else biological like perimenopause irritating us that we need to balance it out? Because once we are sleeping through the night, there are a million other things that are going to get better throughout the day.
Mhm. Yeah, it's great advice because I remember in my 20s and 30s, I used to pride myself on how little sleep I needed. And even when I had little children, I'm like, look at me, I can still function. Now in my 40s, I'm like, how much sleep could I get? Now I'm trying to outdo my own record. It's so funny, but it's true because it does affect literally every function of your body, physically and mentally, like you
It's
said. So
I
it's
think it's the
really
most
important.
important thing. I think it's more
Yeah.
important than drinking water.
Yeah.
Having a good night's sleep.
For sure, and I just read an article that said that women actually need more sleep than men because they're using more brain cells,
I was
apparently.
very surprised. I read the same article and I thought that I needed my 6 hours, and I was like, "Turns out I
Yeah,
need more. I am underperforming during the
absolutely.
daytime."
Is absolutely because of all the things that are going through our brains. So, when a woman is long term ignoring or pushing through these signs and these symptoms, what is the cost if we're not addressing these signs and signals that are coming up from our bodies?
I think eventually it's mental health. We're going to have depression and anxiety, and we don't understand what it's from because we don't have cancer and our periods are regular, right? We feel
Right.
like sometimes those are the standards for being healthy, but it's
Yeah.
really not. It's everything else. So the work stress has to be tampered down. The personal home life, child caretaker stress has to be tampered down. The sleep has to be improved. And then we can listen to our body and see what we really need. Other things about balance, which actually I do notice in high performing women, is that they are really good about exercising, hydrating, and taking care of themselves, which is very important. I have to stress the importance of a multivitamin. There's absolutely no way we can sufficiently eat all the supplements that we need to eat, even if we're doing a really great healthy diet. Multivitamins are very important. Probiotics are very important for gut health, as well as hydration. And again, the sleep. And when we
Yeah.
balance out the stressors in our life and supplement the true natural supplements that we can do, we can see if there what else is going on, if there's any true medical condition underlying the imbalance that we're feeling.
Yeah, that makes a lot of sense. A lot of us think, "Oh, I don't have cancer or my periods are regular. I must be healthy or I'm
But
fine." And we like to tell ourselves we're fine. And we try to make ourselves believe that lie and others believe that. But it's really a spectrum, right? Of like all the different things you should be doing for your health. And there's so much more there. So I think that's a really important point. Now, I want to talk to you about a connection that a lot of women maybe don't realize exists because as a trauma informed coach, I see a lot in my practice women who are carrying unresolved trauma. And 70% of adults globally have experienced at least one traumatic event in their lifetime. And in the US, over 50% of women have reported at least one traumatic event, which means, in theory, half of your patient population has experienced trauma. So I would love to understand from your perspective how that is showing up in women, because we know that trauma isn't about what happened to you, it's about the imprint it leaves behind. We know that trauma is stored in the body and it can often manifest as, physical symptoms, a dysregulated nervous system. But I'm curious, what are some of the gynecological symptoms or things you're seeing in your practice that can actually be rooted in unresolved trauma?
so there's a lot of trauma in general that people can experience, as I'm sure you know. As a gynecologist, the trauma that I really see is sexual trauma and physical abuse. That's what I encounter most. And for some people, it causes an aversion to relationships in general. Just people who are no longer interested in intimacy. They don't find any pleasure in it. They find pleasure in only platonic relationships. Um, Other times, it comes out as severe pelvic pain and discomfort with their partner, and discomfort with my exams, discomfort with anything to do with things gynecological. And that causes a compounded trauma because these women many times want to go on and have children. And when you are pregnant, you require a lot of care around the genitalia, and that's very difficult. So when I see these kinds of patients, it's when they have to be honest and open up with me to express their trauma. And we always first talk about therapy to see if they've worked through that. Most patients actually have. Most patients do seek out therapy, which I think is really great about this day and age, about how open and good that is. But the next step would be to see what their personal goals are, their personal life goals. If they want to have a successful, vaginal penetrative relationship, if that's a goal, at all. And if they want to do childbearing, we discuss that. And then we plan with pelvic floor physical therapy. I briefly discussed that before. They're magicians. I love them very much. I personally have had pelvic floor physical therapy. I think it's really important to explain how that works because many people don't even know what that is. So, as a gynecologist, the trauma I see is really genital, reflected in the genitalia and the over stressing of the pelvic floor muscles. A little bit more biologically into the science here, the pelvic floor involves the bladder, the vagina, and the rectum. All of those are interconnected by the pelvic floor muscles, and you can have dysfunction in one or all of them. So, frequent urination, loss of urine, um, pain with intercourse, pain with having a bowel movement, all of that is trauma for the pelvis. And all of that can be treated first with pelvic floor physical therapy.
Interesting. So you touched upon something important there. I want to go a little bit deeper without getting too far into the science. But if it wasn't a sexual trauma, maybe some other form of trauma, there could still be a connection to gynecological symptoms. So I'm curious as to like, how does that happen? What's what the kind of the high level science behind that?
So, we actually don't know what causes pelvic floor dysfunction. And sometimes I see it in virginal women, women who have never been exposed to anything and don't have any gynecological trauma. And something is triggering it. It's probably a trauma that's undiscussed or something that I don't normally deal with. And it can happen over time. A woman who has been living her life, bearing children, everything is fine. And all of a sudden, she has pelvic floor dysfunction, severe, unable to tolerate anything. And this is a difficult thing to understand and to diagnose. And a woman who thought that everything's been fine for 35 years, all of a sudden she can't have sex with her husband, it's causing even more trauma, right? Because he's
Sure.
upset, she's upset, she doesn't know what's wrong with her. Nothing's ever been wrong before. So this leads us down a road of one, discussing conversation, two, again, the pelvic floor physical therapy, and then three, evaluating what could have happened and how we can assess that. And many times, I feel like in relationships, it's overuse. So the childbearing, that was probably the trauma, or issues with the partner. That was probably
Mm.
traumatic, and the vagina, the pelvic floor has shut down. Work stress, and no longer the science behind women's orgasm and desire is also complex. So the hormone pathway is probably off, leading to discomfort during the sex event. It's a lot of conversation and probably requires a lot of therapy for resolution.
Yeah, you touched upon something important there, which is, a lot of us have had traumatic experiences and, have worked towards, worked on therapy or other healing modalities. Some of us don't realize that we've actually experienced trauma and, or maybe have also downplayed, dismissed, or just really didn't fully understand or acknowledge what has happened in the past. So I think understanding that is really important from your perspective to know that, yes, some people may know about it and be very acutely aware, and some may not. And also just the state of the world we live in is very stressful. So I think those are all really great points. And I know you work a lot with perimenopausal, menopausal women and HRT. I would love to know, there's been a lot of shifts in that perspective, from the research and the science and how we are now treating it. Where do you think the medical system is still failing women, and what would you like to see continue to change?
So I have a long answer to that question. I trained at Albert Einstein. I was trying to remember when I trained. I think I graduated in 2018. So I trained from 2014 to 2018. And I had three mentors who did hormone replacement therapy. And there were tons of mentors, but there were three of them. And they really told us to be bold and brave with hormone therapy. And women really need this, and they really need this. So you have to do this. And I felt very lucky because then in private practice, I left academia after my training. And I've only been in private practice ever since. And I've always done hormone therapy. It took me a while to get my feet wet. I was also a little bit nervous and then prescribing birth control pills. But the first year out of residency, you actually do a lot of education and training for your boards. So I actually learned about a lot about menopause and perimenopause in training for my boards, which then spilled into my practice. I felt like that was
Mm.
really useful. Some people take years to take their boards. I really hate tests, so I took it as soon as possible. And I thought it was very educational. And I've met a lot of people in private practice who do a lot of menopause care. So we have a lot of conversations about it and increase knowledge. But in such a wonderful academic program that I was in, there were three providers who spoke about it. And I had to seek out the education on my own, and I had to maintain the education on my own. And I felt that maybe my patients were telling their friends to come see me because I do provide menopausal care. And I recently went to a menopause conference, and the people I was sitting with, the people that I was meeting, not a lot of them were gynecologists. I thought that was very interesting. I met a lot of endocrinologists and a lot of
Mhm.
primary care doctors, not a lot of GYNs. Just in the circle, I'm sure they were there. There were plenty of gynecologists there. But at the table that I was sitting at, I thought I would see a ton of gynecologists there, but a lot of
Yeah.
other people are branching into this medicine. And another thing I see in my office is patients are declined by other physicians. I'm usually not their first stop. I'm usually the second or the third stop. They've already seen another gynecologist who refuses to prescribe or prescribes birth control. They've seen an endocrinologist who's a hormone therapist who refuses to prescribe, or their primary care doctor says, not in my scope of practice. And that's fine. That's what I'm there for. So I think that one, it needs to be a conversation in residency. We are clinicians, gynecologists. We are office clinicians. We do office practice. I think that when you're in the hospital, the way that residency is made is you are made to do procedures and to think about procedures. I
Mhm.
felt a very small amount of my time was in the office when now 100% of my time is in the office. I'm a clinician.
Sure.
And I think that there was really not enough stress to make it think that it's our problem. Like if you have BV, a gynecologist knows that it's their problem. If you have BV, you have a yeast infection, you have a breast mass, I know it's my problem. But we need to be retrained to think that perimenopause is our problem. We need to fix that.
Mhm.
And I think
Mhm.
that the science is pretty good. The education is pretty good. There's a lot of treatment modalities. I don't think it's a complex thing. I think there just needs to be more training when we are early baby doctors to teach us that this is important. Also, shared knowledge. I talk about it with my peers and we make sure that we're kind of up to date if something new comes out. If I'm doing a new interesting combination of medications, we discuss. You want to continue your education.
I've heard that from other providers as well, that academia and residency, the training hasn't quite caught up to the
Yes.
science and the practice yet. So I think that's a great point. I know in your practice specifically, you are very attuned to symptoms and not just looking at lab numbers, but that is not the experience, not the case for everybody. And so a lot of women are dismissed, to your point. You're either coming to you second, third, fourth
Right.
stop. Or misdiagnosed or told everything looks normal because the labs came back normal, but they know something is off. Can you talk to us about what you're seeing in your experience and what we should be thinking about?
I think it's misogyny. I think it's the medical misogyny that we are trained with because we are trained to heal men. We are trained to heal men. The anatomy is on men. Everything
Mhm.
is, as we grow up about men. And how many times I was dismissed as a nurse or an assistant in the room instead of the doctor or the doctor in charge, especially since I started medical school when I was 21, was very
Mhm.
dismissive. So I think it's our inherited misogyny from our physician forefathers that people's symptoms and that people think that they think lots of things and they're wrong because they're not the doctor. And the doctors only work based on science and labs. But the reality is we are limited in our Western medicine. We do not know everything. We are not at all even taught about the Eastern medicine types, which I
Sure.
totally recommend to all of my patients for things that I can't find in my textbook, right? There's a limit to our knowledge. So we have to be open to that. And truly, I think the reason is misogyny. And when I was a baby doctor, also, I did the labs and I told my patients, your FSH and your LH are normal, your estrogen and progesterone are normal. I don't care that you have hot flashes, you're not in menopause. And now I say, I don't care what your labs say, I'll just give you the estrogen. I said, I'm sorry you have the hot flashes, I'll listen to you. I think it's growth and education
Mm,
and listening to your patients. Yes, I have the knowledge, and yes, I'll do the research, but I have to guide you. You have to make your decisions. And I can't give you medicine that you don't want. And you shouldn't take medicine that you don't want. And if you want
sure.
medicine and it is safe for you, I should be able to give it. So I think that it's important to treat women. And, many women come into my office with these symptoms and the labs are normal, labs are not done, whatever it may be. But if it is unsafe for me to give you the medicine, I actually can't. So
Sure.
that's another thing. Some women want it, but they can't have it for various reasons. And
Mhm.
to go back to answer your question, I think it's because we're taught originally not to listen to what other patients are feeling and to listen to the lab work.
The myth around women are being dramatic or too much. I think it's quite the opposite. We're actually downplaying a
Yes.
lot of the symptoms.
Yes. Yes. I could count on one hand in a week about how many times I complain about my physical ailments versus how many times my husband complains about his
Right.
physical ailments.
We
and
should
live
do
it
a
at home.
study on that alone.
So, I agree with you. Women, like I said in the beginning, we are told to tone it down, that no one's interested in our problems and that we're overreacting. And then when we actually say something, we have to believe women when they actually say
Yeah.
something hurts or something
Yeah.
bothers. We have to believe them.
Absolutely. So, along those lines, what would you say are the top 2 or 3 symptoms that women are commonly experiencing that we should stop ignoring? So maybe we think they're common, so therefore we think they're normal and we don't say anything. What would you recommend we stop ignoring?
Sleep issues, any sort of sleep issues, they should be
Mhm.
investigated. You should be able to sleep through the night. Your anxiety shouldn't be keeping you up. And what is your anxiety from? We need to address sleep issues. So that's first and foremost. And the second one, I think, which is a really big one that people don't think to complain about, is mood changes. So anxiety and low mood. We think that it's due to. It could be due to anything, but especially around the perimenopausal age, it's due to perimenopause. And
Mm,
you don't have to be on antidepressants or anxiety medicine. I could just supplement your estrogen or your progesterone and help you feel better. So,
yeah,
anxiety and sleep, and those will impact, like we talked about earlier, everything else in your productivity throughout the day and your self worth and yourself, healing and able to do all the other things that you need to do. So, I think that if you're having mood changes or if you're having sleep issues, especially in the perimenopausal years, should discuss that because those could be treated with hormone replacement therapy and be really an easy fix.
absolutely. Such a great point. And just before we wrap up, I would love to know if women, for the women listening, if what is one thing you want them to take away from this conversation?
I want you to make a list of the things you want to discuss with your doctor. Make a list. I think it's the best way to make sure that all of your questions are concerned. And I want you to, when you go see your medical provider, I want you to make sure that they're spending time with you and not spending 5 minutes and running out of the room. You're never going to get the care that you need. Your doctor shouldn't be
Yeah.
running away. And make a list because that way you know that you've discussed everything you needed to discuss. And that is really old advice that, I received when I was a medical student and I've been giving everyone ever since.
Such great advice. It's so important because when it lives in our head, we forget.
We all carry a
Yeah.
phone. Make a list.
Yeah, absolutely, even if it's on your phone. Amazing. Dr. Faina, this has been such an incredible conversation, so empowering, so informative. I want to thank you so much for being here, for sharing your insight and expertise.
Thank you so much for having me, Gia. This is wonderful.
Amazing conversation. And so for our listeners who may be interested in learning more about you, where can they find you?
Oh, absolutely. So my website is northjerseygyn.com. I'm located in Oradell, New Jersey, and that's the name of the practice, North Jersey GYN. I'm a solo private practice provider at this time. So if you are calling our office to see someone, you will be seeing me.
And in addition to your clinical practice, you also have a med spa, correct?
Yes, I do have a med spa. And I have to tell you that every gynecologist office private practice I've ever worked in always did aesthetics. So to me, it was just a natural flow of things when you leave academia and go into private practice. So we do have a med spa in my office. I'm also the solo provider there, and that's called Dr. Faina Aesthetics and Medi Spa.
Incredible. So one-stop shopping.
It is.
Thanks so much. We'll put that link in the show notes. Thanks, everyone. Thank you, Dr. Faina. And if this landed, share it with a friend who's having the same thoughts at 2 a.m. And if you want more conversations like this, stick around because this is where we make shift happen. Take care. We'll see you next week. All right, shifters, before you jump back into your day or back into your thoughts, if something from this conversation stuck with you, that's not random. A shift doesn't happen because you push harder. It happens when you stop ignoring the thing that keeps coming back. So here's your only ask. If this episode made you think of someone, send it to them. That's how these conversations are spread. Quietly, honestly, person to person. This is What the Shift.